So today we'll have a discussion on history taking, clinical examination and management of epigastric mass. As you know, it's an important clinical topic and it's the exam case for undergraduates as well as for postgraduates. So what do you mean by the epigastric region?
So it's the area of the abdomen which is bound by the transpyloric plane inferiorly and on either side by the clavicular lines.
Fine. So in this you'll have different planes, right? You'll have parietus, intraperitoneal and retroperitoneal structures.
Yes, sir.
So these are the anatomical structures. In exam, if you see, mostly intra-abdominal, intraperitoneal masses are kept for undergraduates. Whereas for postgraduate, they keep any mass in the epigastric region.
Okay, sir.
So you should have a thorough knowledge on clinical examination and discussion on an epigastric mass.
Yes,
If you have any case scenario, if you have, you can present.
Yes, sir. Will present, sir.
Okay.
Mrs. Kanniyammal, a 50-year-old female coming from Perumbakam, she's a housewife. She came with the chief complaints of upper abdominal pain since 4 months, loss of weight since 2 months and loss of appetite over 2 months. Coming to the history of presenting illness, she was apparently normal until 4 months ago when she developed upper abdominal pain, which is insidious in onset, non-progressive, located in the epigastric region, dull aching, continuous, non-radiating. There are no specific aggravating or relieving factors and it is not associated with food intake.
So the upper abdominal pain of 4 months, what all did you think of? In a 50-year-old female, what all did you think of?
So first, my differential diagnosis would have been maybe a gastric or duodenal ulcer, so peptic ulcer disease.
Correct.
Second, maybe chronic pancreatitis.
Correct. You won't think of acute problem because the duration is 4 months.
Yes.
So gastritis and other things is unlikely. So as you rightly said, you have to think of a chronic problem, right? So 4 months, what you thought of acid peptic disease, any duodenal ulcer, gastric ulcer is okay. And what is the relationship with food? Why did you ask that? Not associated with food intake.
So to identify whether it is a peptic ulcer disease, sir.
Okay, what happens in gastric ulcer?
So in gastric ulcer, on food intake the pain is worsened, whereas in duodenal ulcer with food intake the pain reduces.
Correct. So normally after food intake, immediately if the pain occurs, it means it's a gastric ulcer, right?
Yes.
So food aggravates pain in gastric ulcer, whereas food relieves pain in duodenal ulcer. So that you should be very clear. Right. Now you said there is loss of weight, right?
Yes, sir.
2 kilos in 2 months.
Yes,
And it is unintentional.
Yes.
So now having taken this history, so what all you thought of?
Sir, loss of weight is usually a constitutional symptom. Given her age being 50 years, I have the suspicion of some form of malignancy at the back of my mind. So.
Correct. And you said it's unintentional, right?
Yes, sir.
So obviously you have to think in terms of malignancy, right? Because if it is due to food pain, she would have avoided food.
Yes, sir.
Then in that case we'll think probably nutritional.
Yes,
She's scared to take food because it can aggravate pain. So it becomes intentional, right? So
Yes.
you have clearly meant it is unintentional loss, right?
Yes.
Fine. Then
Loss of appetite is also present over the past 2 months, sir. She is unable to take food because of the pain.
pain. Okay. Right. And early satiety is also present, right?
Yes, sir.
So what all these 3 symptoms take us to like?
So there are classical symptoms seen in carcinoma of stomach, sir.
So mostly it's a malignancy, right? So mostly malignancy you'll have all these symptoms. Okay.
Yes.
Right. So pain will be a symptom in malignancy at what stage?
Usually in advanced disease, sir.
Mostly it's advanced disease. Okay. Okay, go ahead.
Coming to the negative history here, sir. There is no history of vomiting, no history of hematemesis or melena, ball rolling movements, constipation, dysphagia, abdominal distension, jaundice, cough, breathlessness or hemoptysis or back pain.
Okay. Now you explain me why you asked all these things. Why vomiting is important.
So vomiting could be an indicator whether there is any outlet obstruction in the stomach, sir.
Good. Right. Then
Then
hematemesis and melena.
in case of any upper GI bleed, sir, to rule
So
out.
mostly if it is malignancy, so they can have subtle bleed. If there is a massive bleed, they can have hematemesis. If there is a subtle bleed, they can have melena.
Melena.
So what, can you define melena?
So black, tarry, sticky, foul-smelling stools.
Why it is black?
Because of conversion of blood into acid hematin.
So why it's sticky?
So it's sticky because of breakdown of the contents by succus centricus.
Why it's foul smelling?
Due to action of gut anaerobes on the contents.
So colonic flora can give that foul smelling thing. Fine. Next is you said ball rolling movements. What does it
Yes, sir.
indicate?
So usually that indicates peristalsis against an obstruction.
Fine. So in this case, why did you ask that?
Sir, to give us any clue whether it's benign or malignant etiology, sir.
Fine. It excludes, gastric outlet obstruction, right?
Yes.
So if there is ball rolling movement, obviously it indicates that there is an obstruction.
Yes.
Okay. Right? In ball rolling movements, it will be significant in which condition? Malignancy or benign?
Benign, sir.
It can be in both, but more evident in benign condition, because in benign condition, the stomach, musculature, hypertrophies and hyperplasia is also there. Whereas in malignancy, when there is outlet obstruction, the tumor infiltrates the muscular layer, so you don't expect hypertrophy or hyperplasia. But still, there is a dynamic obstruction, there will be peristalsis against the obstruction, so patient can have ball rolling movements.
Yes, sir.
Fine. Why did you ask about constipation?
So when there is reduced intake and reduced appetite, sir, the patient may have reduced formation of stools, resulting in hard pellet-like stools.
So mostly that is present in gastric outlet obstruction. Okay. Fine. You have asked about dysphagia, right?
Yes.
Why?
Sir. Sir, in proximal tumors, either near the gastroesophageal junction or fundus, they may present with dysphagia.
So GE junction tumors, or as you rightly said, it's in the fundus and the cardia. The dysphagia may be the main symptom. Okay. Right. Why did you ask about abdominal distension?
Sir, when there's diffuse abdominal distension, it could be an indicator of ascites. If there is localized lower abdominal distension, especially in a woman who is perimenopausal, it could indicate any ovarian tumors also, sir.
Actually, abdominal, we are suspecting malignancy because of the symptoms what she is having, right?
Yes.
So malignancy, as you know, it can have a direct spread, it can have a lymphatic spread, it can have a hematogenous spread, and it can also have a transcoelomic or transperitoneal spread. So because of transperitoneal spread, you anticipate ascites.
Yes,
So ascites, as you rightly said, you will have a overall abdominal distension. But as you said, in a woman, okay, it can be even a pelvic ovarian tumor and a secondary, what we call as Krukenberg's tumor, that can grow upon and can present like a localized lower abdominal or pelvic distension, right? So why did you ask about jaundice?
Sir, if there are secondaries in the liver, it may present with jaundice, sir.
So there are two possibilities in a cancer stomach, right? So the lymph node metastasis, again suprapyloric or close to the porta hepatis, can cause obstructive jaundice. So jaundice can be deep jaundice, like a obstructive jaundice, associated with pruritus and passing clay-colored stools, if it is due to the nodes in the porta hepatis or a pre-pyloric node obstructing the lower CBD.
Yes, sir.
Or it can be due to hematogenous spread to the liver through the portal system. So what happens in that case, you get mild jaundice. So what percentage of liver should be involved to present as clinical jaundice?
So more than 70% of the liver should
Correct.
be.
70% of the liver, but in alcoholics it may be 50%, right?
Okay, sir.
So 50% of the liver involvement in an alcoholic can clinically present as icterus. But in a normal individual where the liver is normal, 70% of the parenchyma should be involved to clinically present as jaundice. And what did you ask about cough, breathlessness and hemoptysis?
So if there's hematogenous spread to the lungs, sir.
Good. So hematogenous spread is one. Another thing, important thing in this case is, if they have a GO, gastric outlet obstruction, they vomit. When they vomit,
Yes.
being elderly, the reflexes may not be that good. In that case, they can aspirate. So lower basal pneumonitis can occur. That can be the cause if the patient is vomiting. In this particular case, you have asked because to exclude metastasis, right? You
Yes.
can get pleural effusion and also through hematogenous spread, lung involvement, right? That again can cause cough with hemoptysis. Back pain, why specifically back pain you have asked?
So one is that there may be posterior infiltration into the pancreas.
So what forms the stomach bed?
The pancreas.
Mainly the pancreas. So when the tumor infiltrates the pancreas, they'll have back pain, right? So that indicates that the tumor has infiltrated the pancreas. But in this case, why do you think the dull aching pain is there? Even adjacent structure involvements can cause pain, right? But back pain is very specific to say the tumor has infiltrated the stomach bed and patient will have classically pain radiating to the back, which will be relieved on bending down like in pancreatitis.
Yes, sir.
Okay.
Coming to the past history, sir. She has no known comorbidities. There is no history of acid peptic disease or use of proton pump inhibitors.
Why did you ask that?
Sir, chronic acid peptic disease can be present with ulcers, sir.
Very good. So one is gastric ulcer, right? Gastric ulcer can turn malignant. Intractable ulcers which are not responding to your H2 blockers or a PPI can turn into a malignancy. That's called ulcer cancer theory. Another important thing which you have asked is about acid peptic disease in the past is H. pylori. So H. pylori, as you know, is the main factor not only for acid peptic disease, also for malignancy. Especially CA stomach, it is one of the main etiological factor. So that will tell us whether we are dealing with the H. pylori induced malignancy.
Okay, sir.
Right. Then past surgical history, nil you have asked. What is the important past surgical history you ask?
Sir, whether the patient has undergone any procedures for peptic ulcers.
Okay. When do you want subject surgeries for peptic ulcers?
Sir, usually if there is any emergency, sir.
Complications, okay.
Yes.
So complications of peptic ulcer can be acute complication or a chronic complication. So what are the acute complications you know?
So it can either perforate or there can be bleeding.
Which ulcers perforate?
So anterior ulcers perforate.
Anterior ulcers perforate. So what will be the treatment, surgical treatment in anterior ulcer perforate?
Cosco-Graham's patch repair
Patch
with
repair.
omentum.
So you close the perforation then with the omental patch, that is called Cosco-Graham's procedure. Cosco-Graham's procedure. Other than that, what else will you do? You have to do a thorough peritoneal toileting because it depends on the contamination of the peritoneal cavity. Depending on that, you do it. Okay, right? That is done for perforation. So then, what is other acute complication you can come across?
Bleeding, sir.
So bleeding. So which ulcers bleed?
Posterior ulcers.
So which is the artery that bleeds?
Gastroduodenal.
Gastro. It just lies behind the first part of duodenum, the posterior wall. So posterior ulcers penetrate. So it can cause a bleed from a. What's the surgical treatment for that?
So we have to underrun the ulcer.
Underrun the ulcer, right? You are going to open the duodenum and see underrun the ulcer and ligate the gastroduodenal artery. When you do that, you'll be doing a pyloroplasty.
Yes.
Again, to reduce the rebleed, you may have to do a vagotomy. Okay, that can be done according to the surgeon's choice and the age of the patient. Younger patient, there can be vagal stimulus for gastric secretion, so you do it. In an elderly patient, there can be autonomic neuropathy, wherein you need not do a vagotomy. So depending on the patient conditions, right? So what are the chronic complications mostly you come across in a duodenal ulcer?
There can be cicatrization.
So it can be a cicatrized duodenal ulcer, which we call it as pyloric stenosis. So when the first part ulcer cicatrizes, the pylorus gets stenotic. So we call it as pyloric stenosis. In such case, what will you do?
Sir, in such cases, we have to relieve the obstruction. So we'll go in for a
Truncal vagotomy with posterior gastrojejunostomy. So in that case, what happens? The bile enters the stomach, okay, and it causes biliary gastritis, which is otherwise called alkaline gastritis, which can again lead on to intestinal metaplasia, and you can get malignancy in that. So post vagotomy GJ status is almost a pre-malignant condition.
Okay.
So that's why you should ask about past surgical history in patients. Okay, that's important. Okay, fine. Now you go to personal history.
She consumes a mixed diet. There is no history of smoked, salted, spicy or nitrous food intake.
Why that's important diet?
Sir, the specific type of diet itself can be a predisposing factor.
So what is the carcinogens in that?
So nitrates and
Nitrosamines. Okay, nitrosamines are the ones. That's why salted, spicy, smoked food, okay, can trigger a malignancy. We call it as carcinogenesis, right? These are all carcinogens that can cause carcinogenesis. So that's why if you see like in Japan, most often they take smoked food and other things, right? So that's why the incidence they say is very high. Okay, other than hereditary and other things, okay, that's again a triggering factor. Diet plays an important role. That's why you should ask a detailed diet history. Okay, fine. Normal sleep.
Yes, sir.
Okay,
So having normal sleep and reduced appetite, normal bowel and bladder habits, there is no history of alcohol consumption or smoking.
Why did you ask that?
So they are both individual risk factors for malignancy.
Okay, good. Right then.
Coming to the menstrual and obstetric history, she has one child which is through normal vaginal delivery. She is having regular menstrual cycles of 4 by 30 days. Coming to the family history, there is no history of malignancies such as gastric, colorectal, pancreatic or ovarian malignancies in the family.
Why it is important?
So gastric CA can sometimes be hereditary or familial.
Very good.
And it can also be associated with syndromes such as Lynch syndrome or Cowden syndrome.
Good. So that's why it's important, right? So the family history is mandatory in case of epigastric mass. Okay, right. Go ahead. Then.
So coming to the examination, sir, she is poorly built and nourished, height of 163 centimeters, weight of 45 kgs, BMI is 17.5 kg per meter square, ECG score is 0. A pallor is present. There is no icterus, cyanosis, clubbing, bilateral pedal edema.
Okay, fine. What does pallor indicate in this patient?
So pallor could indicate nutritional anemia,
Fine.
or second it could be pernicious anemia, which in itself is a risk factor for gastric carcinoma.
So pallor itself can give us idea that she has pernicious anemia and that has led to malignancy. Okay, that's one possibility. And there can be subtle bleed that can cause. And number three, what happens is patient's intake has come down, right? There is loss of appetite, you said, and early satiety, you said. What do you think the reason for early satiety could be?
So if there is infiltration of the muscular layer, then there is loss of distensibility of the stomach. So
that's again an important symptom of gastric cancer. Okay, so that's why probably even nutritionally they can have pallor, right? Fine. Why did you ask about icterus?
So icterus can indicate
actually you
liver.
told in the history itself you told that there is no history of jaundice. Okay, as you rightly said, to know metastasis either in the porta hepatis or liver mets. Cyanosis not much needed for this particular patient. Clubbing again is important because clubbing can show, especially if it's a male, can be alcoholic. That can give us an idea that patient is having alcoholic liver disease. Okay, and if he has jaundice, again we can contemplate alcohol for cause of malignancy, and jaundice also cirrhotic liver cause associated with that. Okay, why pitting pedal edema?
So this can be due to multiple causes, sir. First, it can be due to poor nutrition in severe anemia. Second, if there is hypoalbuminemia also, it can present with pedal edema, sir.
And again, patient who is vomiting, okay, pre-renal
Yes,
uremia again can cause pedal edema. Okay,
sir.
right then.
On examination of the left supraclavicular fossa, a single node of 1 cross 1 centimeter, which is firm, non-tender and mobile, is palpable. No other lymph nodes are palpable.
Left supraclavicular is quite broader area, right?
Yes,
so
sir.
where exactly did you feel the node?
It's palpated between the two heads of the sternocleidomastoid.
What is the node called?
So Virchow's node.
Virtues. What is the sign called?
Troisier sign.
Troisier sign. What does it indicate?
It indicates advanced malignancies.
It's already a metastatic disease. Okay, it has from the stomach. It has reached the supraclavicular region. Actually, after epigastric examination, you can do that, or as a part of general examination, you can do it. So, as a part of general examination, when you find this node, you you have high suspicion of a malignancy. So you will
Yes,
thoroughly examine the abdomen. And after examining the abdomen, if you suspect malignancy again, you will feel the supraclavicular. Either way it can be done, right? As a part of general examination. Then why did you ask about no other lymph nodes palpable?
Sir, very rarely when the left supraclavicular node is palpable, there may be backflow of the tumor cells retrograde spread, which can go up to the left axilla, sir.
That's okay. But as such, you think of lymphoma also.
Yes, sir.
So stomach has lymphoid tissue, and lymphomas also can present like a CA stomach.
Okay, sir.
So if you pick up generalized lymph node enlargement and the epigastric mass, number one, it can be a CA stomach or it can be a paratic lymph node which you are palpating.
Yes, sir.
So that's the importance of generalized lymph node enlargement in
sir.
such epigastric masses. Okay, right, go ahead.
So, examination of the vitals. The pulse is 80 per minute measured in the right radial artery with normal volume. The blood pressure is 110 by 70 millimeters of mercury measured in the right arm in sitting position. She was afebrile with a respiratory rate of 16 per minute.
So vitals plays a major role when the patient has vomiting, because patients can go for hypovolemic shock. So in that case, they can have tachycardia, hypotension. Okay, in that case, patient who vomits, again in your general examination, you should look signs of dehydration.
Yes.
Okay, in an adult, where all will you look for signs of dehydration?
So, we look for skin turgor, sir.
Very good.
Dry coated tongue.
Very good. So these are the most important things, okay? Sunken fontanelle, sunken eyes and all are for pediatric age group. In adult, you mainly look for skin turgor and tongue. Okay, if the tongue is dry, what next will you ask? About the output, urine output.
Yes.
How frequently? They may say like passing scanty urine. That says patient is already going for hypovolemic shock.
Okay, sir.
Okay, in such case, patient may have also pedal edema.
Yes, sir.
Okay, go ahead.
So, inspection of the abdomen. The abdomen is distended with all quadrants moving well with respiration. The umbilicus is in the midline, inverted and pushed downwards. No nodules are seen. A visible fullness is noted in the epigastric region. There is no visible peristalsis or pulsations. There are no sinuses or dilated veins. A scar is seen over the left hypochondrial region, 2 centimeters long, and it's healed. The flanks are free. Inguinal orifices are free. Renal angle appears free.
Fine. Abdomen, what is the normal shape of the abdomen?
So, scaphoid.
It will be scaphoid or flat. So what does distension indicates?
Probable free fluid within the abdomen.
So remember 3 F's. Fluid, flatus and fetus. Okay. Being a woman, but of course 50 years that's different. But remember these 3 things. Okay. So if there is intestinal obstruction, there is gas fill. We call it as flatus, right? Same way, if there is ascites, it is fluid. If that, you will have this thing, right? Abdominal distension. So distended abdomen shows there is some underlying pathology. Of course, to add to it, fat, obesity. Okay, central obesity again, they can have abdominal distension. Okay, right? Then you said all quadrants move with respiration. Why it's important?
Sir, if there is any mass or such thing, it may be.
So usually that we look for acute abdomen. Okay, if there is any peritonitis, okay, or any right iliac fossa mass, appendicular mass, there is inflammation there, or when there is acute cholecystitis, the right quadrant will not move, because as you know, parietal peritoneum is sensitive. So when the parietal peritoneum touches the inflamed organ, patient can have pain. So the movement will be restricted. So that's mostly for a acute abdominal conditions.
Okay.
For a chronic, you need not tell about that. You said peristalsis, right?
Yes, sir.
So there is visible fullness noted in the epigastric region alone. So what could be the causes?
A probable mass.
There can be a mass. Okay, it may be either from the stomach or even a retroperitoneum, or it can be a pseudocyst also. We are not sure because we have not yet palpated it. On examination, you see fullness. So this fullness most often can be mistaken for a peristalsis. So
Yes,
that's
sir.
why I said no visible peristalsis or pulsation. Okay,
Yes,
so how do you elicit peristalsis? Normally peristalsis you get when the patient has vomiting, okay, or when they have ball rolling movements. Okay, and also they give classical history of induced vomiting, which all says there is gastric outlet obstruction.
Yes, sir.
Okay, So most often you look for peristalsis in a patient who is vomiting.
Yes, sir.
Understand? So what sort of peristalsis you expect?
So the gastric peristalsis.
So
will be
visible
seen.
gastric peristalsis. How does it look like?
So the direction of progression will be from the left hypochondrium towards the epigastrium and coming towards the right hypochondrium, sir.
That's right. So what are other peristalsis you know of?
Intestinal peristalsis, sir.
So it's called VIP.
Yes, sir.
Okay, it is a step ladder pattern where you get it in intestinal obstruction.
Yes,
And
sir.
what is the most common cause of intestinal obstruction?
Adhesions.
Inner, you have to classify it to inner virgin abdomen. That is, now
sir.
surgery has been done. You have to think of obstructed hernias.
Okay, sir.
Okay, if there is a surgery already undergone, patient has undergone a surgery, then you should think of adhesions.
Okay, sir.
Okay, then in our country, you have to think in terms of ileocecal tuberculosis.
Yes, sir.
Okay, these are the common cause of intestinal obstruction. Okay, so you have to, and with peristalsis you will see mostly in a subacute form of obstruction. Acute obstruction, they'll have severe abdominal distension, followed by colicky pain, vomiting.
Yes,
Okay,
sir.
so but here, when you see peristalsis, sort of subacute obstruction. Okay, right. Then what are the peristalsis you know of? Very rarely you can see colonic peristalsis.
Okay, sir.
Okay, when left-sided colon, okay, there is a stricturous type which can obstruct. Patient can have a peristalsis from the right going onto the left side. Okay, that is colonic, quite rare. So you said no sinuses or dilated veins.
Yes, sir.
Why? So mostly it's as a routine you need not tell. As undergraduate, fine, they can tell. But what sinuses do you anticipate? If they have undergone a surgery or anything, intracutaneous fistulas
Yes,
can
sir.
present and other things. Okay, dilated veins, of course. We can tell you patient is having portal hypertension or not. So you said there is a scar. Is there any relevance to this particular patient?
No, sir, not.
It's just a finding.
Yes,
so
sir.
as a PG, whatever you find, you have to tell, right?
Yes,
so what you have done is right. There is a scar. Whatever is there, you see, you're supposed to explain. Good. Right. Orifices, inguinal orifices are free. Fine. Renal angles also appear free. Good. Fine.
Yes, sir. This is an image of the patient.
Yeah, you can see the fullness in the epigastric region, almost coming to the umbilical region as
Yes,
well.
sir.
Okay, not fully confined to the, but most of it is in the epigastric region, and partly it has come to the umbilical region as well.
Yes, sir.
Okay, you see the fullness. Accepted. Right.
Coming to palpation, sir, there is no tenderness. A mass of size 5 by 4 centimeters palpable in the epigastric region. It is ovoid in shape with a nodular surface moving with respiration. The plane of the swelling is intra-abdominal, intraperitoneal. Overlying skin is normal. All borders of the swelling are palpable. I am able to insinuate my fingers beneath both costal margins. The swelling is firm in consistency and has intrinsic mobility.
Fine. So, mostly shape, ovoid, okay. What you felt is okay. Most often it will be irregular in shape. Okay.
Okay, sir.
Fine. If you feel a ovoid thing, okay, no harm in telling it, right? So, it's ovoid, nodular surface, moving with the respiration. Why do you say it's intra-abdominal, intraperitoneal?
So first, because it's moving with
Fine.
respiration.
Only intra-abdominal, intraperitoneal swellings will move with respiration. That itself tells it's intra-abdominal, intraperitoneal. Okay. Why you want to tell the skin is normal? Overlying skin is normal.
Sometimes if it is a parietal swelling, there may be stretched, shiny skin with any
Fine.
inflammatory signs.
But when it is obviously moving, we will exclude parietal swelling.
Okay, sir.
Okay, same way, in exam, I have found out many students telling there is no local rise of temperature. In abdomen, you don't expect, except for a abscess, okay, or any inflammatory swelling in the parietus, you expect local rise of temperature. As a general abdominal examination, no tenderness is acceptable. Okay, whereas don't tell there is no local rise of temperature.
Okay, sir.
Okay, right. You said about pulsation. Okay, no visible pulsation seen. Same way you have to, over the mass when you feel, whether you can feel the pulsation is important.
Okay, sir.
So that will tell you whether the mass is sitting over the aorta. One. So feel a pulsation, you have to differentiate two things. Whether it's a transmitted pulse or an expansile pulse.
Yes,
If
sir.
it is a transmitted pulse, maybe a mass or a tumor sitting over the aorta, which is transmitted. Whereas if it is a expansile pulsation, right? It means it is aneurysm, aortic
Okay, sir.
aneurysm. You have to be very careful and safe in examining it.
Yes.
Okay, so that's why pulsation is important to feel as well, not only seeing, to feel as well. Okay, right. Now extend it, ma'am.
Yes, sir. The extent of the swelling is the superior border is 2 centimeters below the xiphoid process. Inferior border is 7 centimeters below the xiphoid. Laterally on either side it is 2 centimeter medial to both midclavicular lines.
So this is one way of presenting, but you can always tell there is a mass in the epigastric region extending to the other quadrants.
Okay, sir.
Okay, like I said, it is extending to the umbilical region as well. You need
Yes,
not
sir.
describe in detail, but most important is you said you felt the superior border.
Yes, sir.
Why it's important?
So it can help us differentiate between mass which is arising from the liver.
Correct. Left lobe of liver. Okay. So if you are not able to insinuate, it's likely to be a liver mass, which again will move with respiration. So that is one thing, right?
Yes,
so that's why you have to see the upper border, and you have felt all the borders. That shows that probably it is not a liver mass.
Okay, sir.
Okay, right. Other than that, you have look for hepatomegaly.
Yes, sir.
You said no mass palpable. What are the other masses you anticipated and palpated?
So one can be peritoneal nodules, sir.
Okay.
Second is any pelvic mass.
Okay. Peritoneal nodules and pelvic mass most often you get through transcelomic spread.
Yes, sir.
There will be ascites, but of course minimal ascites cannot be made out on palpation. Massive ascites, of course, you will see, and when you feel itself, you will have a fluid trill and other things, right? Whereas mild ascites can be there with omental deposits, pelvic deposits, and all. Any other organ would you like to palpate? Spleen.
Spleen.
Okay,
Yes, sir.
spleen. Because the tumor, if it infiltrates the pancreas, the superior border of pancreas has a splenic vein, so it can cause that obstruction to the splenic vein, and patient can have left-sided portal hypertension. Splenomegaly can be there.
Yes, sir.
So you have to look for spleen as well. Okay.
Hernial orifices are free and renal angles are non-tender, sir. This is an image, sir.
So as you rightly said, it's mainly occupying the epigastric region, and it is coming to your umbilical region.
Yes, sir. On percussion, percussing over the mass, the tone is impaired. The liver span is 12 centimeters. There is no free fluid per abdomen. Sir.
Fine. Okay. So you said mass is impaired. When do you get dull note?
When it is arising from a solid organ.
Fine. So liver, if it is a liver mass in the epigastric region, it will be dull. Okay. You said impaired. So impaired means what?
It is arising from a hollow viscous.
So, fine. If it is resonant, what does it mean? It's a retroperitoneal tumor.
Yes.
So there is stomach in your head, and obviously it will be gas filled and it will be resonant. So a dull note indicates it's a liver. Impaired note or impaired resonant indicates it's from the stomach, and if it is resonant, it indicates it's a retroperitoneal mass.
Okay.
So that's important, right? Then no free fluid per abdomen you have mentioned. What did you do? What all did you do? See, obviously fluid trill you won't do because there's not much of distension.
Yes,
Okay,
sir.
obvious distension, right? So what do you do?
So for minimal distension, we can check for puddle signs.
And what else will you do?
Or shifting dullness.
Shifting dullness. So what does it indicate, shifting dullness?
That
Moderate
moderate
ascites. When do you call moderate ascites?
More than 500 ml.
More than 500 ml up to 1500 ml. More than 1500 we call it as massive ascites.
Yes, sir.
Okay. So less than 500 ml we call it as minimal ascites.
Okay, sir.
Okay, right. Fine. Auscultation, you had bowel.
Bowel sounds are heard, sir.
Fine. So, but when there is a VGP, okay, when there is a visible gastric peristalsis, and when the patient has classical symptoms of GOO, like vomiting, we'll do a test called auscultopercussion.
Yes,
That
sir.
will outline the stomach. Okay, that will tell you the greater curvature of the stomach. So, if it is a benign condition, you can see even the greater curvature going up to the pelvis.
Yes,
So, it
sir.
will be long. So, that will tell you are dealing with the benign conditions. Auscultopercussion you don't do routinely, but when there are symptoms of gastric outlet obstruction and when there is a VGP, then you have to do that. Along with that, again, succussion splash can be done.
Yes, sir.
But succussion splash, before you do, you should ask the patient when was the last meal.
Yes, sir.
The gastric emptying time. So once the gastric emptying time occurs, after an hour or so, if you see, there may be a succussion splash. Otherwise, normally also when you take fluid and see, you can have a succussion splash.
Okay, sir.
Okay, right. Per vaginal,
Per vaginal examination, there is no fornical fullness, sir.
what is it? If there is fullness, what does it indicate?
A possible ovarian mass, sir.
Possible secondaries in the ovary.
Yes, sir.
Okay, right.
On per rectal examination, there are no mucosal nodules palpable. Normal stool stain gloves, sir.
So, what did you look for? What is it called?
So,
Deposits there.
they are called Bloomer shelf deposits.
Shelf. Why do you get it? How do you get it?
So, because of transcelomic spread.
Transcelomic spread. So, mostly after this, we will examine the supraclavicular. Fine, you have examined the supraclavicular node first. Fine. So, how does it reach the supraclavicular node?
Sir, the lymphatics of the GI system are drained into the cisterna chyli, sir. This drains further into the thoracic.
That's a lymph sac, okay? That's a lymph sac in the retroperitoneum in close proximity to D12 and L1 transverse process.
Okay, sir.
So, all the lymphatic goes there. From there,
It drains into the thoracic duct, sir.
through the thoracic duct, it drains into
Into the junction of left IJV and left subclavian vein.
subclavian. So, it goes there, right? And no, it goes through the posterior mediastinum. So, there will be fluctuation of pressure because of constant breathing. So, in that case, there can be spillover of lymph which has malignant cells.
Okay, sir.
Okay, that node traps it up. That's the node which you call it as Virchow's node.
Okay, sir.
Okay, right. Go ahead. Then,
So, coming to the systemic examination. Examination in the respiratory system, there is bilateral air entry. CNS, there is no focal neurological deficit. Spine and skeletal system, there is no tenderness. CVS, S1 and S2 are heard. Breast and thyroid examination are normal.
fine. Good. Why did you examine breast in this patient and thyroid in this patient?
So, first breast, because that can also be a cause of the left supraclavicular node, sir.
Right. So again, I mean, as a routine you have examined, okay,
Yes,
but
sir.
when you have found out a mass in the stomach, as a routine you have to do it and you have to examine it. Right, fine. Then,
Yes, sir. So, that's all.
fine. So what will be your diagnosis?
So, in this patient, my diagnosis would be probable carcinoma of stomach. So,
Fine. So it is a intra-abdominal, intraperitoneal with symptoms of CA stomach.
yes, sir.
Okay, and on examination also you have found out a irregular mass which is firm, and on percussion it is giving impaired resonance and it is mobile, right?
Yes, sir.
So it means that there is a possibility of mass arising from the stomach. Okay, right, fine. Would you like to give any DD from the stomach? It can be a
Yes,
gist.
sir.
Remember, it can be a gist. Gastrointestinal stromal tumors also can present like this.
Yes, sir.
Okay, right. If the same thing was a ovoid which is not mobile, what do you think of?
Retroperitoneum.
Retroperitoneum. It can be a lymph node,
Yes,
or
sir.
if there is a history of pancreatitis, it can be a pseudocyst of pancreatitis.
Pancreas.
Okay, right? But in men, remember, you have to examine the scrotum and look for any testicular mass. As you know, a testicular mass can go to the parietic nodes and that can present as an epigastric mass.
Yes, sir.
Okay, so if it's a retroperitoneal mass in men, you should also think in terms of a testicular tumor going to the parietic nodes. Again, patient can have a supraclavicular node.
Yes, sir.
Fine, so that's a possibility you have to always think.
Okay, sir.
Then how will you proceed?
So, for evaluating this patient, sir, first I'd like to start with blood investigations. I'll begin with a complete blood count.
So here in this patient is having pallor, so you anticipate hemoglobin anemia. So hemoglobin to be low.
Yes, sir.
Right, fine. LFT. Then
Yes, sir. Second, LFT, sir.
why LFT is important?
I'd like to assess the nutritional status as well as if there's any liver function derangement, sir.
So that will tell us whether patient has any liver mets.
Yes, sir.
Okay, right. Then
Then renal function test with serum electrolytes, sir.
fine. Especially patient vomits, you have to do it. And of course, patient is also having less intake of food,
Yes,
loss
sir.
of appetite. In that case also, okay, serum electrolytes can be deranged.
Okay, sir.
Okay, coagulation profile.
Yes,
What do you mean by that? Why you want to do that?
The coagulation profile includes PT, PTT and INR, sir. Most likely, I will be subjecting this patient to endoscopy and intervention. So for that, I would like to
Endoscopy and biopsy. Biopsy
Yes,
itself can bleed if the
Yes,
patient has impaired coagulation profile.
Okay, sir.
X-ray chest.
So to look for any pleural effusion or parenchymal nodules.
Okay. ECG.
ECG is the baseline. So
Yeah, you have to. Patient has to be taken up for anesthesia. They obviously ECG is mandatory. Right then.
then coming to a specific investigation, I'd like to start with an ultrasound of the whole abdomen and
So
pelvis.
what all information you can get in ultrasound?
So first it can tell us the site and the location of the mass, where it's originating from, the extent and possible infiltration, sir.
Good.
It can also tell us about the status of the liver, presence of any nodules, tell us about free fluid in the abdomen and also of the pelvic organs.
Okay. And lymph nodes, if they are more than 2 centimeter, it can be picked up by ultrasound.
Okay, sir.
Obviously, free fluid, even minimal fluids can be picked up by your ultrasound. Okay.
Yes,
So nodes which are less, and you said you can infiltrate. Infiltration very difficult to find out by ultrasound. Of course, of late we do get high frequency ultrasounds and all can make up. But for pancreatic bed involvement and infiltration, the CECT will be the most appropriate
Okay, sir.
investigation. Can you add anything to the upper GI scopy? What all will you look for in upper GI scopy?
So the site of origination of the tumor.
First you localize the tumor. In this case,
Yes,
where
sir.
it's likely to be?
Probably in the body of the
Body of some. Because patient doesn't have dysphagia, doesn't have outlet
Yes, sir.
obstruction, and she has presented with only pain and there is a mass.
Yes,
So
sir.
more likely to be from the body of the stomach. So you see a lesion, then
Then the extent of the lesion,
extent
sir.
of the lesion, then
Ability to maneuver the scope beyond the lesion, sir.
obviously you can do it because there is no outlet obstruction.
Then I'd like to take biopsies from the lesion, sir.
Okay, how many biopsies would you like to take?
So 6 to 8 biopsies.
6 to 8 biopsies you have to take and mention where all you have taken.
Yes.
Okay, right. Then
Then, sir, I'd also like to look at the fundus.
fundus. Okay, right. Good. Then
And then, other than that, we can also employ endoscopic ultrasounds.
if you have a facility, endoscopic ultrasound can tell you again the T lesion.
Yes, sir.
T staging can be assessed. Okay, right? Can you
Yes,
tell
sir.
about the T staging?
So, in carcinoma of stomach, T staging goes by T1 being involving only the mucosa, T2 it's involving submucosa but not breaching the muscularis. In T3 the muscularis layer is breached and T4 there is serosal spread.
Okay, fine. So that will tell you. Okay, then CECT. So
Yes,
what all
sir.
CECT can tell you other than ultrasound?
So, other than the ultrasound, CT can tell us about
Liver mets of size, smaller sizes, nodes of perigastric nodes of smaller sizes, and tumor infiltration, tumor bed
Yes,
infiltration, stomach bed infiltration. The plane between the pancreas and the stomach can be delineated with that. Other than that, even smaller deposits can be picked up.
Okay.
What can a CT miss?
It can miss a peritoneal metastasis.
Small peritoneal metastasis can be missed by CT. Not only CT, even PET CT can be missed.
Okay, sir.
So what will be the ideal investigation in that case?
So, diagnostic laparoscopy.
Diagnostic laparoscopy can pick up small peritoneal deposits.
Yes, sir.
Okay, go ahead. Then
In this patient, these are the investigations.
these are the investigations you did. Okay,
Yes,
there is gross anemia, total counts are raised, all these things are there, right?
Yes, sir.
So how will you proceed now?
So, first you'll have to
So
correct.
CECT, based on the CECT, you'll plan, right?
Yes, sir.
So correcting the anemia is mandatory. Improving the nutritional status of the patient is mandatory. So either through enteral feed, elemental feeds, you can improve the nutritional status. And if there is any dyselectrolemia, correct the dyselectrolemia. Then if there is anemia, you have to transfuse blood and bring up the patient at least to 10 mg% of hemoglobin.
Yes, sir.
Okay, only then wound healing will be perfect, anesthesia will be comfortable, all this. So you have to transfuse and prepare the patient.
Okay, sir.
Okay, then based on the CT, even if the CT is there, then you do a diagnostic laparoscopy. Then you plan accordingly.
Okay, sir.
So what all will you see in diagnostic laparoscopy?
So first we'll look for any ascites.
Very good. As soon as you put in a scope, you look for any fluid there, right?
Yes, then we'll assess the liver.
Peritoneal deposits. Okay.
Yes, sir.
Liver. Then
Pelvis.
Then open the lesser sac,
Okay,
gastrocolic omentum. Then go in and see about the pancreatic infiltration again.
Okay, sir.
Right. Then you assess. Then you can plan for surgery accordingly. So what would you like to do if it is operable?
So based on the site of the lesion.
Okay,
sir.
say this is in the body. What will you do?
If it is in the body, then I'll go for total gastrectomy, sir,
Radical.
with esophagojejunostomy, sir.
Okay. If it is in the distal thing,
Then we can do a subtotal gastrectomy with a gastrojejunostomy, sir.
very good. So then rest of things are theory like D1, R1, R2, all resections. Okay, you can do it. But all those things are early gastric cancers.
Yes, sir.
Yeah, whenever you have a palpable mass, okay, in the epigastric region, as you rightly described now, it mostly what you are going to do is a palliative surgery.
Yes, sir.
Okay, so it's mostly a palliative surgery wherein you have to do it, followed by what you will do?
So adjuvant chemotherapy.
Adjuvant chemotherapy has to be given. Fine. When you are doing a scope, you see there is infiltration. Then what will you do?
Then we can do a palliative gastrojejunostomy.
There is no obstruction, no. So when
Yes,
there is
sir.
no obstruction, you can come back, give neoadjuvant chemo.
Okay, sir.
You can downsize the lesion, then you plan for surgery.
Yes, sir.
The best palliation will be resection.
Okay,
So
sir.
resect it, then you plan for adjuvant. Not
sir.
able to resect, give neoadjuvant, then plan for surgery.
Okay, sir.
Early gastric cancer management is entirely different gamut. But when a mass is kept, it is almost an advanced. That too, in this particular patient, there is no role for surgery.
Yes, sir.
Why? Supraclavicular node is there.
Yes, sir.
Already it is a disseminated disease. When there is a supraclavicular node, it becomes a disseminated disease. So now you tell me, what are the clinical signs of inoperability?
So presence of ascites.
Start from head to foot. If there is jaundice, obviously
sir.
liver mets.
Yes,
Deep
sir.
jaundice, nodal mets. Okay, pale jaundice, liver mets. Okay, then supraclavicular node. If present, it's a disseminated malignancy.
Yes,
Then
sir.
come down. If there is pleural effusion, then it means it's a disseminated malignancy. Abdomen, ascites, umbilical nodule,
Yes,
palpable liver. Okay, then pelvic deposits.
sir. Okay, sir.
All these things are clinical signs of inoperability,
Yes,
wherein
sir.
you can do only palliative care.
Okay, sir.
You can give chemotherapy and that's it. Fine. When there is obstruction, then you can plan for what will be the best palliation in an inoperable case with obstruction.
So we can do an anterior gastrojejunostomy.
No, inoperable case. When there is ascites and all, the ideal thing will be do an endoscopy, laser luminization and SEMS, self-expanding metallic stent. That
Yes,
will be
sir.
the best palliation you can give. But as you rightly said, when you do a diaglap and see inoperable, then you can do a anterior JJ.
Okay,
Then,
sir.
so that you relieve the obstruction and you can improve the patient's nutritional status. Then you give chemotherapy. Then you downsize and do it. But
Okay,
once you get a left supraclavicular node, it becomes an inoperable CA stomach.
Okay, sir.
Fine.
Yes, sir.
So now we are very clear how to go about and examine. Okay.
Yes, sir.
Then present a case of epigastric mass, mostly arising from the stomach. Then the examiners can ask you, if it is being a postgraduate, they can ask you, fine doc, if it is arising from the pancreas, what are the possibilities?
If it's a retroperitoneal mass, then I would think if there is
If
history
it
of
is not mobile, okay,
Yes.
you think of retroperitoneal mass. From pancreas, don't forget the cystic neoplasms of pancreas, number one.
Okay,
If
sir.
the patient gives classical history of acute pancreatitis leading on to such a thing, remember pseudocyst of pancreas.
Yes, sir.
Okay, so these are the things you will think if it is the retroperitoneal.
Okay,
Very
sir.
rarely you can get a retroperitoneal tumors.
Yes, sir.
Okay, you can give a soft tissue, sarcomas can be there.
Okay, sir.
Okay, that is quite rare. But in this region, epigastric region, mostly you'll think of stomach mass or a liver mass. Liver mass is unlikely in this particular patient because it is able to reach the upper limit, and you can insinuate your finger between the mass and costal margin, and you can feel all the borders.
Yes,
So
sir.
it is from the stomach only. In case if it is stomach, you think of CA stomach or a chest.
Yes,
If it
sir.
is retroperitoneal, the most important structure in that region is pancreas.
Yes,
You have to
sir.
think of a pseudocyst, or you should think of a cystic neoplasm of pancreas. Because CA of pancreas or other things will not be clinically palpable.
Yes, sir.
Clear?
Yes, sir.
Right.